So welcome and thank you for joining us tonight. I'm going to give a couple more minutes and we will start at 2 minutes past 7 o'clock, just to allow time for everyone to enter. So, good evening. Thank you for joining us on the 1st of November. I'm Ed St. John. I am the co-founder and the Chief Medical Officer of Concentric Health. I'm also a practicing NHS consultant surgeon, and I'm going to hopefully host this webinar. I'm going to share some slides first and talk about innovations in digital consent. I'll introduce Concentric Health, and then we'll have see some research data that's been happening, and we'll have a discussion with some other consultants and experts about what it's like to introduce Concentric into your practice. So consent in numbers. Is this a big problem? Well, about 300 million operations and procedures are performed across the world each year. And if we just look at NHS England, that amounts to about 10 million operations and procedures. So that really means that every day many patients are consenting to undergo procedures that really fundamentally determines their future outcomes and therefore their qualities of life. And the problem with the consent process is that consent forms have these two sort of divergent roles. One is to act as an educational tool to inform patients about risks and benefits, but the other is to act as a sort of medical legal document to prove the patient has entered into this agreement with us. Well, the Royal College of Surgeons in England has said that unless we make changes to this process, we're going to see dramatic increases in litigation. So I think most of the audience will be very familiar with the paper-based system of consent, which still is done up and down the country, where you write out the procedures, the benefits, the risks, and these are really based on the Department of Health templates that were provided many years ago now. But in the last decade, there's been increasing evidence to show that these are littered with errors of eligibility, errors of omission, lack of standardization, and loss of documentation. It's also an expensive process. So if we look at NHS resolution data, which is the department that deals with litigation for the NHS, over a 5-year period, they had 1,025 claims as a direct result of failure to warn or consent problems directly, and that doesn't include all the many other claims they had for which the consent form was part and parcel of helping to defend the claim. So that amounted directly to £226 million over 5 years. So if you break that down into an annual cost, that's over £50 million. That's about £50 million a year. So the other thing is the NHS long-term strategy has said that all healthcare providers should transition to digital records by 2023. So there's been a lot happening in consent in the last few years. The General Medical Council have updated their guidelines in November 2020, and they've really stressed the importance of having a meaningful dialogue with the patient, discussing alternatives with the patients, and having a truly shared decision. NICE have updated their guidelines this year on said shared decision-making tools, and the Royal College of Surgeons have also updated their guidelines on consent. And all of these updates have really been based on the back of several legal landmark cases. So Montgomery versus Lanarkshire now happened back in 2015. So I hope most people are now aware of this, but this really changed the process by which used to be called the Bolam principle, which used to err on the side of what an expert panel of consultants thought. And now it says the law errs on what a reasonable patient deems as appropriate. Defalt versus Johnson is a spinal case which really showed that consenting on the day of surgery is not legally valid, and it gave the principle for time for consideration for elective surgery. And the Patterson inquiry also went on to say there should be time for considerations, you shouldn't be consented on the day of surgery. And it also went on to say that patients should be written to in lay language explaining their clinic letters and their consent. So all of this has really created a perfect storm that has resulted in digital consent now having a place for which it could be useful. And there's several things that support digital consent. So let's look at why you would want to use digital consent. So the first is this paper that we published in the British Journal of Surgery earlier this year. And we looked at a cohort of handwritten consent forms in general and breast surgery, and then we compared this to a semi-digital product for procedure-specific consent. And here we showed that looking at the handwritten consent forms, there was about a 50% or over 50% error rate in the paper-based forms, and this was statistically improved down to 7.5% for this semi-digital process. We also looked at core risks, and we found that the paper-based consent forms were missing over 90% were missing core risks. And then we looked at variations in what was said, and we found that the handwritten consent forms mentioned typically per procedure less risks, but with a lot more variation than when we compared it to the semi-digital that mentioned more risk per procedure with less variation. The other thing digital can do is it can enhance information. So it allows the ability to link multimedia information. So that's videos, that's other web sources, that's providing lay information. Another benefit is remote consent. So the Royal College of Surgeons during COVID produced this statement saying that consent forms can be sent electronically to the patient, and that really allowed the use of electronic consent nationally. The benefits of remote consent, well, it does save the need for an in-hospital appointment. Therefore, it can reduce CO2 emissions. That's of particular relevance this week for the COP26 conference. And it gives patients time and space to consider their decisions, something patients say they really like, and it allows involvement of families and their friends. Finally, efficiencies. Well, the NHS has a record waiting list at the moment of nearly 5.5 million. And the paper-based consent process, we all know, is time-consuming, and it's often performed on the day of surgery, and it often results in lost forms, and that causes delays to going into theatre and sometimes cancellations. And you have problems, particularly if you're working on a hub-based model, because you need to transfer your paper-based consent form across different sites, and you have storage issues and scanning issues if you're trying to put it onto an electronic healthcare record system. Whereas digital consent is inherently secure, compliant, and you're able to have remote pre-op pathways. And to that end, the NHS-X have recently just funded specifically focusing on electronic consent as their priority for 2021-2022. So with all this in mind, we started building Concentric, which is a digital consent platform, and it's now been in use in a number of NHS hospitals and some private providers, and in the UK and internationally. So I'm just going to show you a quick demo of how this works. So I'll let Daph, our CEO, talk you through this.
Let's see a demo and see Concentric in action. First off, creating an episode. To create a consent episode for a patient, you search for the patient and land on their record. Here you can see all previous consent episodes and create a new episode. Concentric is used across all specialties and for all procedures and treatments, with evidence-based templates accessed instantly through live search. This includes searching using acronyms and synonyms, making search really fast. We know that lots of the time you're not just doing one procedure, but a combination. That's no problem in Concentric, with the flexibility to get to exactly the treatment information you need. When you've selected the treatment, Concentric provides a template of information for the treatment and does an intelligent merge where a compliant procedure is selected, containing only the relevant information. Once the treatment has been selected, it's easy to prepare and personalise the consent information for your patient. As a clinician, you select only the information that is relevant to the patient, including indications, alternatives, anaesthetic options, and risks. Often, information will be quickly selected off the template, but with Concentric it's simple to modify as much as is needed, add custom elements, and add notes to any section. On average, it's 40 seconds quicker to prepare consent information through Concentric compared to using a paper consent form. You're then ready to share the information with the patient. We see Concentric being used in many different ways by clinicians, depending on pathways and preference. Concentric information may be shared during consultation or following, and in clinic, at the bedside, or remotely. ConcertView takes the prepared consent information and shares it in an accessible, structured manner that can be engaged with as part of a consent conversation or outside a consultation. Each element contains rich content and signposting to additional resources, supporting patients and clinicians to make informed, shared decisions. Risks are presented by timing and likelihood, and again supported by lay descriptions and context of what a risk might mean for them. Notes again can be added throughout the process, for example here to document a discussion around material risks. Content and templates can be customised at an organisation level, as well as including links to other local resources. Information is shared digitally or in print with patients, and if appropriate, remote consent can also be enabled. Giving consent through Concentric follows a clear, stepwise approach that can be done in person with a clinician or remotely. Any additional consents can be given as part of the process, for example here for blood transfusion and medical photography. Depending on whether you're on a touchscreen, either a method to hand off to sign on another device is presented, or a signing pad, and the patient's signature is recorded. If done prior to the day of treatment and consent is confirmed, the consent form is generated and usually sent into the main electronic health record. It's time for digital consent.
So hopefully that gives you an idea how it works. So bit of data now. So we've done nearly 18,000 consent episodes through Concentric so far. We've got exponential growth being taken up in a number of different specialties and hospitals. Our age range ranges from 0 to 102 with a median age of 58. So it can be used for paediatrics and it can be used for anywhere in between. Consent statistics, 25% of our patients are being consented remotely at the moment. About 55% are being consented on the day of surgery. Now, I've already spoken about how we shouldn't really be consenting on anyone on the day of surgery. This number was a lot higher and we've been driving this down, and and using this data with trust to help them drive down their on the day of surgery consent. I think this is part of change management, and as we show managers actually what is happening on the ground, a lot of them are surprised to see how much consent is happening on the day of surgery, and it's up for us as clinicians to try and show them that we need more time to be able to do this before the day of surgery. And then 82% of the consent forms are shared digitally. That means they're emailed a copy, with the rest being able to be printed out a paper-based copy if they want. So here's some patient feedback. So this is across over 2,000 patients across 23 specialties. And we asked them several questions, and they were rated out of 1 to 5, 1 being strongly disagree to 5 being strongly agree. So the question of I was provided with all the information I was needed in the online application was 4.5. I found the process simple, 4.5. I found the process more convenient than a paper form, 4.1, and I'd be happy to use Concentric again, 4.1. So all of them leaning on the agree to strongly agree. And the overall rating of Concentric from 1 to 10, with 1 being poor and being excellent, rated it as average of 8.9, but a big skew towards the upper numbers. So these are very good net promoter scores that we're very happy with. In terms of free text feedback, this is a few selected ones, but essentially patients are finding it very useful, convenient, easy to use. They find it straightforward. They like having time to think about what was being said and then being able to read it in advance rather than signing on the day. And it overall speeds up the process. Clinician feedback in a smaller cohort, but they again rating 1 to 5 rated it as an average of 4.7, with 5 being amazing and 1 being awful. And rating the quality compared to paper as 4.8. And with a time trial of performing a consent on paper or on digital, it was about twice as quick to fill out the form using Concentric. In terms of supporting Concentric use across the trust, 100% of the clinicians we surveyed said they would. So barriers to adoption, well, we'll, I think, discuss this in a bit more detail with the other speakers, but information governance and getting it in and having discussions with IT and getting buy-in that this is a product that is needed. These are the hurdles. We know there's an innovation adoption life cycle, with the first few percent being the innovators and then moving on to the early adopters. And I think right at the moment with digital consent, we're just transitioning to the innovator stage and to the early adopter stage, but we've still got a long way to go. But I think within the next few years, digital consent will be here to stay. There's a number of other providers that also exist providing other platforms. And I think soon digital consent will be the standard. And the late majority will join, followed by the laggards. So in summary, and I am biased, but I think digital consent is the way forward. But you've heard enough from me. Now let's hear from Rory. I'll just close my screen and hand it back. So now we're going to hear from Rory Dyke, and I've asked Rory Dyke to present some of his research data that he performed this year. So Rory is a core surgical trainee. He's currently working at Lewisham and Greenwich. He's interested in trauma and orthopedics, and he recently completed a master's degree at the University of Edinburgh, where he wrote his dissertation on the comparison of digital consent, looking at Concentric, and the paper consent process in trauma and orthopedics. So we're very honoured, Rory, to have this presented live. So thank you.
Hi, well, thank you for having me, Ed. So as Ed so kindly introduced me, I'm Rory. I'm a core surgical trainee working in Lewisham, and this is a presentation of the research I did as part of a master's degree at the University of Edinburgh. The platform we used was, of course, Concentric, and it was at Imperial College Healthcare NHS Trust. So it's a comparison of error rate, omission rate of core risks, and most importantly, shared decision making between paper and digital consent processes. So, as Ed has outlined already, why does the consent process, particularly in trauma and orthopedics, need changing? As has been discussed, the current process is mostly paper-based in most places that I've worked, where a paper consent form signed after a discussion of the risks and benefits of an operation. This is then signed by the clinician and the patient. However, this is known and has been known for many years to be associated with errors of completion, illegibility, and omission of key risks to patients. These can also be lost and frequently are. And as a result of the errors I've mentioned, £238 million was spent in the year 2018 to 19 in orthopaedic surgery alone by NHS resolution, which is an absolutely astronomical amount of money. The digital consent forms such as Concentric can offer us a traceable electronic record of the consent encounter, which can't be lost, a solution to these errors of illegibility and completion, and prompts for essential information, key risks that clinician want to include in the consent form, so that you don't miss material risks that may be pertinent to a given procedure. They also, as has been shown by the video that Daph showed before, give an opportunity for patients to have multimedia information about their surgeries and furnish themselves with a bit more understanding perioperatively. So the aims of my study were to compare the error rates of digital and paper consent forms, to compare the number of what were deemed core risks omitted on both paper and digital consent forms, and to compare the proportion of patients who achieved what's termed a gold standard of shared decision making between a paper and a digital format. Alternative hypothesis was that digital consent forms are an effective tool in improving the documentation of patient consent in trauma and orthopaedic surgery, and that they're likely to reduce the number of errors on consent forms, discuss more what are deemed core risks with patients, and afford a higher quality of shared decision making. We'll go on to discuss a little bit more about what core risk and what shared decision making is slightly later on. So, as I said, this was a study that took place at Imperial College Healthcare NHS Trust. We included 223 patients with 114 consented using the Concentric digital platform, and 109 giving their consent using paper forms. This was all patients undergoing trauma and elective orthopaedic surgeries. The consultant in charge of each patient's care decided which method would be used for the patient to give their consent, so it wasn't formally randomized. However, we got a good number of patients in our study, and these are only patients who were undergoing 20 of the most common orthopaedic procedures in the trust the previous year. So we defined a set of core risks for each of these 20 procedures via a multi-stage Delphi round with 5 orthopaedic consultants. And then we compared consent forms filled out by paper to those filled out via the Concentric platform, assessing the error rate of the consent forms and the omission rate of these core risks, how many were mentioned, how many were not mentioned. We also assessed shared decision making, which is an area that digital consent forms or digital consent platforms seem to improve patient satisfaction significantly. To do this, we used the Collaborate Top Score, which is a validated tool to assess shared decision making, whereby patients answer 3 questions about how included they felt in the decisions that were being made. If a patient answers 9, which is the maximum to all of these questions, they're deemed to have achieved a gold standard of shared decision making. The results were then analysed using chi-squared and Mann-Whitney U tests. So in terms of our results, the graph shown over to the right of your screen shows the stark differences that we found. 72% of the paper consent forms contained at least 1 error, compared to no digital forms, due to the way that the forms are built in the consent platform Concentric. It was virtually impossible to make the same sort of errors that were made on paper forms, such as not filling out a certain field or forgetting to sign it, as the form would not be completed doing this. Less than 2% of the digital forms admitted any core risks, while 63% of the paper forms admitted at least one. The Royal College of Surgeons guidance on what should be included in a consent form changed during COVID, specifically that the risk of contracting COVID whilst undergoing any surgery should be mentioned, and this was the most commonly missed core risk for any procedure that we saw. And most importantly, in my view, 72% of the patients who used the Concentric platform deemed themselves to have achieved a gold standard of shared decision making, compared to just 28% using the traditional paper process. And obviously all of these results were highly significant. So what are our key findings? The paper-based consent processes continue to show errors. They have done in lots of different studies in the past. However, a clear solution to this hasn't really been sought. People have tried to use procedure-specific pre-printed forms. However, these don't allow for patients to, for clinicians and patients to discuss individual risks that may be tailored to that patient. And the Concentric platform and digital consent is something that offers this. We found that a digital consent process may provide a solution to a safer consent practice and potentially reduce future litigation costs, especially in light of the £238 million figure for just trauma and orthopaedics in the year 2018-19. Patients self-reported a higher quality of shared decision making, which is important, especially with recent GMC and NICE guidance suggesting that we need to do a lot better with regards to shared decision making throughout medicine, but especially regarding consent for surgery. A digital consent process is a logical next step to a healthcare system which is largely shifting towards a digital process. Obviously, there are challenges to this. However, the NHS long-term plan is for the entire NHS to be digital by 2023. It remains to be seen whether that will happen, but it's my view, and it's backed up by the research that we've done, that a digital consent process will be a very logical next step. Of course, challenges remain in the transition to a completely digital healthcare system, but this seems the way forward, as I put it before. Of course, this is a pilot study. This is only at one centre. Further work's required to validate all of these results. However, our key findings were that massively in favour of a digital consent platform when compared to a paper counterpart. There were some limitations to the study. Patients who favour digital consent may have been more likely to participate in a study about digital consent. And additionally, due to consultant preference about how they wanted their patients to give their consent, there wasn't a formal blinding or randomisation. Additionally, we only looked at the Concentric platform, so these results only speak to Concentric and not other digital consent platforms. So to sum up, the implementation of a digital consent process has been shown to not only reduce the error rate and the omission of core risks on consent forms, but it's also shown to increase the frequency of achieving a gold standard of shared decision making, which is what we would all want for patients. Digital consent platforms may provide a clear route to improve the quality of informed consent and patient experience, particularly with reference to the quality of shared decision making. However, we need to do further work, look at how it's implemented in different places to validate this further. So thank you for listening. I'll hand you back to Ed now, if I can stop sharing my screen. Yeah, thank you again.
Sorry, Ed, you're on mute.
Hello, can you hear me now?
Yes, perfect.
Great. I was just saying thank you very much, Rory, for presenting that. Really interesting research data and for giving up your evening to show us that work. I think it's fascinating stuff. I think it's worth saying that the Concentric platform was provided, but no one from Concentric had any input into the data or the analysis. I think the most interesting thing about that really is about the shared decision making. So before we set out on this journey with Concentric, people said introducing a digital consent process wouldn't really impact on shared decision making, because shared decision making is about far more than just signing a form. And they're absolutely correct. It is about far more than just signing a form, but it's about patients feeling empowered with the information provided so that they can make a truly informed decision. And I think that is hopefully what we've started trying to do with Concentric, empowering the patients with information. And I think that's why we're seeing, for the first time ever, I think it's worth saying, I don't think anyone else has ever shown that a digital consent product can improve shared decision making. So that's really exciting stuff, Rory. Thank you for that. So now I'm going to invite Hira Rizki and Paul Lidder to turn on their videos and their microphones. I'm going to introduce them both, and then I want to have more of a sort of panel discussion, and also I want to use this as an opportunity for anyone in the audience to post questions to us using the Q&A function. So just a little bit of background about who you're going to be hearing from. So Miss Rizki is an oncoplastic breast surgeon working at Imperial College, consultant there, has been using Concentrics for the last half year really, and she's going to share her reflections on how she finds using it as a clinician and how she helps her whole team to use it. And then Paul is a consultant colorectal surgeon and the Chief Clinical Information Officer at the Royal Cornwall Hospital NHS Trust. And he's currently led the pilot of Concentric at Royal Cornwall for GI, and is just about to lead a trust-wide implementation of Concentric across the trust. Really delighted to have both you, Hira, and Paul on the call with us. Hira, your video's just gone off. I don't know if you can hear.
Is it back on?
Otherwise.
I can see you.
Your videos already? Ah, now I can see you. Wonderful. Great. So just an encouragement again for any of the audience, do feel free to chip in. I want this to be quite interactive. Use the Q&A, and Sarah, maybe you could help look at some of the Q&A and field questions if we're getting them, if I'm not able to do two things at once, which I know I'm not very good at. So let's start. So here, let's just think about it from using Concentric as a clinician. So firstly, why would you use digital consent? I know at Imperial currently it's optional. You can use paper-based consent or you can use Concentric. So why are you using Concentric?
So there's several reasons why I prefer to use it. Firstly, it takes away, so I might consent a patient differently to my registrar. So it takes away that degree of uncertainty or differences in the consent process and what you're writing on the form. It's all standardized. So that works really well for me as a consultant, that I know that my registrar is going through the same risks and benefits for every operation, and everything on there is listed. So you'll never leave anything out. The whole consent process has significantly changed in the last few years, and it's not about signing the consent form on the day of surgery or signing it in clinic. With Concentric, I can give it to them, email it to them and text it, and they can go away, read it, call in with questions before they sign. So they actually get that time with the consent form to understand what they're consenting to. And I think in busy clinics, in the day surgery unit, on the wards before theatre, we don't necessarily have that time to go through everything in detail. So it is an actual proper consent process, better than it used to be. And that's certainly why I've been using it. And it's standardized. Every mastectomy patient gets exactly the same consent form, is told of exactly the same risks. And it's more detailed than what I would have written. So it gives you the percentages of each complication happening, which we often omit when we're writing our consent forms ourselves. Okay,
thank you. That's really helpful. What do you reckon your patients think about it? You must now have, I've seen you used it for quite a few patients. So how do they find it? One of the criticisms is that often patients are not tech savvy or computer literate. How have you found it?
I've had maybe a handful of patients who haven't been able to access it, who don't have email or a smartphone that they can read it on. But it's really such a small minority. And for them, we print it off and give it to them in clinic to take away with them. So there are ways to circumnavigate that. The patients really, really like it. They'll come in and you'll start talking to them. So certainly if I see somebody for a mastectomy and then give them the option of an implant or a DIAB, I'll send them both consent forms to read through and see them back in clinic. And they are a lot more informed than I have the time to give them in a 15-minute clinic appointment. So they'll come back with a clear idea of what the risks of each are and what they would prefer. So that's also quite a nice thing that we can do, send them the risks of both, that they read them in their own time, discuss it with their family. The other thing that certainly my patients like to make notes, especially when we talk about risks of surgery. And what Concentric's consent form allows us to do is say, actually, you don't have to write this down. It's all written down for you with further information, and it'll be in your inbox before you leave this clinic room. And I haven't met anyone who hasn't appreciated that.
Okay, and what about ease of use? So I know people listening will probably be thinking, look, this all sounds great. At Imperial, you obviously have one of our clinic appointments, but you know, in our hospital, I won't have enough time. Is it a time-consuming process? Is it easy to use?
I'd never used it before I started at Imperial. It took all of 5 minutes to learn, completely straightforward, really easy to use. If anything, it speeds up the time in clinic than finding a consent form, writing it out, and then that carbon copy that goes into the notes that no one can read. It just negates all the need for all of that. So it's definitely a way forward.
And what about, you talked a bit about how you liked it because you could standardise it with your juniors or be competent. How has it been encouraging your juniors to use it, or do your juniors use it?
Certainly in my clinic, all my patients are consented on Concentric, so they will all use it. And speaking to them, they do prefer it than writing out a paper consent form because they know that they won't miss anything. And on the day of surgery, do you remember when we were registrars, we'd come in at 7 a.m, write out those yellow forms. On the day of surgery, all you have to do is draw an arrow on the patient and on the iPad confirm the consent. So it takes away all of that extra admin that happens on the morning of surgery.
Thanks, that's really helpful. I'm going to maybe ask a few questions to Paul and then maybe swing back to you here, or you know, we can open it up a bit. But so Paul, you wear a few hats. You're both a practicing consultant surgeon and you're the CCIO. So I guess the first question is, you know, with your hat of CCIO, why did your trust even want to consider digital consent? What made you come to us?
Well, Royal Cornwall Hospital has been through a slightly difficult time. If you look at CQC reports, we did go into special measures. We also had a raft of never events. I think we managed to get into low double figures. So we excel at some things, but not necessarily things that most people want to broadcast. We had regular CQC inspections. There was a lot of scrutiny around never events, around the consenting process, around marking, around behaviours and cultures in theatres. The WHO checklist tends to become a bit of a tick box exercise, and organisations will regularly pass WHO checklists when they audit it, because it's a bit like a hand washing audit, isn't it? When you see the nurse with the clipboard next to the sink, you know that you need to wash your hands. And we did spectacularly well when we had spot audits on WHO checklists, but the reality is that it does become a bit of an exercise, and so I was quite keen that we shake things up. Consent is something that I've always been quite conscientious over. When I joined our organisation in 2012, we had no pre-printed procedure-specific consent forms for colorectal, and I wrote them all. And I got up to about 26, and it can take 6 to 12 months to actually get them through a forms review group, plain English language, and all of those bodies that you have to go through. So interestingly, more recently, we've had an external audit across all our organisations. We've got 3 hospitals within the trust, but this external audit also looked at private providers that either do choose and book work and looked at consent. And across the 7 domains, 6 domains, there was significant room for improvement around consenting. And Concentric, when we looked at it, delivered at least 6 of those 7 domains and improved the qualities. So it was a bit of a no-brainer for me in terms of having to move to a different system. Paper consent for me is dead. I haven't used paper consent for over a year, and the challenge as a CCIO is you see something innovative in the marketplace, you want to introduce it into your trust, and you suddenly, you're the innovator amongst what seems to be an army of not even late adopters, but the laggards. And lots of clinicians do put up barriers or suggestions as to why you shouldn't do it. And frequent ones are things like digital poverty. Our patients won't understand it, they don't know. But the reality is, I don't think many clinicians have a very good understanding of what the patients want or need, still have that very paternalistic, didactic view of their patients. And one thing that has been great out of COVID is the rapid rollout and digital progression and maturity, not only amongst hospitals, but also amongst patients and their families. First lockdown, I don't know what sales were like for iPads and smart devices so that families could keep in touch and see one another. But it's very hard these days to find a patient that doesn't have an email address or doesn't have a smart device. Since I've been using Concentric, I've probably had 3 or 4 patients that were 80 to 95 who would struggle with the device. But then I've had other patients when I've been doing video and telephone consultations, I've been trying to ring them because it's been set up as a telephone consultation, and they've said, actually, can we not just do it by video? I prefer to do it by video, and they've dialed back in and used those systems. So I think that old term is still the surface. That's become more the norm now, and particularly for areas where, like Cornwall, we've got one acute trust spanning the whole county, and you've got that geographical isolation. It very much empowers patients who can stay at home and discuss the risks. So there's lots and lots of strengths in it for me. But if people want to ask specific questions about it, I'm happy to fill those. But I'd echo everything the hero has said. Is an enabler. When you actually migrate off paper and you arrive, I had a list today. Just by habit, I'll go in at 7:30. But you're thinking, well, how do I spend the time? I spent all my time just doing the electronic prescribing, but I didn't have to do the consents. The patients already signed. All I had to do was click confirm, check they hadn't had any questions that had arisen. And it does empower that shared decision-making agenda, which is core to good informed consent.
Paul, that's really, really useful, actually. Wearing your 2 hats, what's it like introducing this? You did touch on this a bit, and you talked about the sort of laggards and the armies, and clearly I've sort of been there as well, trying to show people that actually digital consent can be useful. It may be better than the traditional method of paper, but from an organizational point of view, from the CCIO point of view, from the audience that are listening, that are thinking, how do I go and talk to my CCIO? How do I talk to my medical director? What are the approval processes needed? What do you need to think about?
I mean, to start, well, we did an exercise where we went to market and looked at lots of different solutions, and we scored some solutions before deciding upon which product we wanted to pilot. So that was the first step. In terms of developing the pilot, you obviously need to speak to your information governance team because you are sharing patient information. I'm now also a Caldecott Guardian as well, another hat that's been thrown on me. You then have to start thinking about your business case in the longer term. You can get the pilot going, and usually companies are very supportive of a sort of a zero fee contract for a pilot, and Concentric have been very supportive in our piloting phase. The challenges around the business case is actually demonstrating the costs. It's very easy when you're going to market and you're going to a provider and they're saying it's this many thousands of pounds for so many consents. In the next tier of 35,000 consents will be this, at 50,000 consents will be that, and it's very easy for companies to articulate the costs. Similarly, when you go to your IT department and you're saying, well, I will need this hardware to support this, it's very easy for them to articulate the cost. So in terms of constructing a business case, it doesn't take an accountant or a whiz kid to sort of build the costings of it. The challenge comes in actually demonstrating the cost savings. We went to our legal department and you can get some indicative figures, but they'll say, well, generally trusts don't usually just get sued over errors in consent, but consent features in up to 50% of the litigation costs of an organisation, and so they can't necessarily single that sum of money out. Similarly, with all the settlements and with the cost of litigation, that's all underwritten, and effectively your costings are, or doing things better, are reflected in lower insurance premiums. So again, they're indirect costs. Trying to go to your publications department saying, how much do we spend on printing out the yellow consent forms? That's, I never got an answer to that one. It was nigh on impossible. And similarly, it's quite difficult with the procedure-specific consent forms, asking all the different care groups or directors, depending on how your hospital's set up, what their printing costs and toner costs and paper costs are, because it's all bits that are coming out of separate budgets and nobody's got a real good handle on it. Now, having piloted it for almost a year, I saw so much value in terms of the improvement in the quality of care and consent that I just said to my team, look, this isn't about the cost of it. This is a quality improvement measure. People get very fixated on trying to make it cost neutral, saying, oh, well, it's going to cost this, but we'll offset those costs by reducing printing costs, litigation costs. And I said, don't worry about that. It's a clinical tool. We need to sell the clinical angle, and this is about quality improvement. It's about safety. It's about governance. It's about shared decision making. And that was the approach I took, and that worked very well in our organisation, in the culture with which we're operating. The other thing I've also found, which hasn't been mentioned earlier, but weighs in on that, when we were doing our WHO checklists, typically you would have the surgeon at the operating table and all the team sat around there or stood doing the silent cockpit, but you would just have a runner holding a paper consent form up that only the scrub nurse could read, and instantly it creates that hierarchical situation and also an environment in which other people feel empowered to switch off because they can't see what's going on. In our theatres, as I guess most theatres these days, we've got big screens, monitors on the walls. So in my list, as I had today, we've got a sort of 46-inch monitor at the foot of the operating table on the wall, so that if people are coming in, they can see what's on the stacks or on the integrated suite. And we have our digital consent form displayed on that large screen, flattening the hierarchy. We rotate the staff that do the WHO checklist, but when it comes to actually looking at the consent form, everybody looks and can verify the patient, hospital number and everything, and they can see what the patient's been consented for, whether they've consented for medical imaging, whether they've refused to have a blood transfusion. So again, everybody's involved in that, rather than it just being a one-on-one thing where people make mistakes. And the scary thing when you look at consents, I've had it as a trainee, where I remember doing a vascular job, and I typical vascular trainee case, you arrive for your shift at 9 o'clock, the handover says you need to hurry up, there's a patient already on the table. You get into theatres, everybody's tutting because they've been waiting for you, and you're presented with a patient who's been draped and has just got one leg presented, and you amputate that leg, and then you look at the consent form and it had left crossed out, right crossed out, left crossed out, right crossed out, and you're like thinking, am I Mr. Never event? Obviously, there's a lot more governance with a digital consent form. You can't amend or change it. You can retract it, you can cancel it, but you're never going to have issues where, somebody at some point has changed it. And I've looked at paper consent forms in our organisation where, there's 3 different sets of handwriting. There's lots of initials where somebody's added something else on as that care has transitioned. The night registrar started the consent, then the day registrar added a bit on, then the consultant went and thought this bit was missing. How can you ever assure yourselves that that's adequate or safe? And what does the patient think of that? Similarly, the other issue is patients don't know what they don't know. They're like surgical trainees. If you don't know about the recurrent laryngeal nerve injury in a thyroidectomy, you're not going to consent for it, and you're certainly not going to worry about it when you're doing your dissection. The more you learn, the more you worry. And it's the same for patients. Patients don't know what they're not being told. So that there's multiple aspects to it, but they're the sort of steps that you go through. And there are laggards around, but that's mostly ignorance, really. When you give them the system, it is so intuitive, it is so quick that you often find that people just want to extend it into everything else. And we've struggled to contain some of the pilot because it's sort of crept into emergency practice, and then you get theatres going, well, I'm not sure about this, and we hadn't invested in all the devices yet for a wider rollout, which is happening now.
Paul, that's been really, really helpful. I think in the interest of time, what I'm going to do is just invite Adam Blackburn, who has given us a pre-recorded 5-minute video to talk on his experience of using Concentric for his private practice. And during that video, I'd really encourage the audience to pose us any questions that maybe we could ask we could answer at the end, just before we close the webinar. So this is your time to ask us any questions. It's worth saying, Sarah, if you're on the line, that I can't see those. It doesn't seem to be working on my system. So I might ask you if you could chip in with those. But for now, I will try and share my screen. I don't know if anyone, Paul or Ira, or can you see and hear?
Yes, we can say it.
Okay, here we go. This is from.
Good evening. I'm Adam Blackburn. I'm a consultant plastic surgeon. I've been using Concentric in my private practice for the last 15 months. Apart from using Concentric and paying their fee for the service, I've got no disclosures. And I have to say that Concentric has revolutionized the consent process. Prior to using this electronic consent system, I was using a paper-based system, which often involved downloading and printing off very generic consent forms from the British Association of Aesthetic Plastic Surgeons. These are very clunky and weren't customized for the patient in front of me. They were often 6 or 7 pages long, and having gone through all the risks, some of which may not have been relevant to that patient in front of me, it often felt like the patient was under duress. They didn't want to waste my time, and they would quickly sign without necessarily truly understanding what I was saying, but wanting to please me and signing it anyway. But so for cosmetic surgery and the bigger reconstructive operations that I do, I always see patients at least twice prior to surgery, and then I would try to go through the risks and benefits again with the patient to make sure they were properly consented. And this whole obtaining consent would take a significant amount of time in outpatients. But since using Concentric, my consultations are shorter, but I think better, and patients get more out of their visits with me. Because what happens is I see the patient, take a history, examine them, try and work out what their motivations are for surgery and what they're hoping to achieve. And then very quickly, in normally less than 30 seconds, I can tailor make a consent form that's specific for that patient. And not just for a single operation, but sometimes adding in 2 or 3 operations. You know, for ladies having a scar revision and a mastopexy and a nipple reconstruction, all of that can be done very quickly on one Concentric consent form that will go through all the risks and benefits of each little bit of the operation. It will also add in any information leaflets that have been pre-written by any of the main associations, whether that's plastic surgeons, ENT surgeons, max fac surgeons. They're all there automatically added on if I want them to the bespoke Concentric consent form. So patients are told at the end of the first consultation that I'll be sending them more information in an electronic format from Concentric. And the idea is that they get an iPad and spend 20 to 30 minutes at least with part of their support network for the post-operative period, going through the consent form and making sure they understand the risks as laid down in the Concentric bit, that they've read through the brochures from the plastic surgeon, from the BAPRAS and BARPS, and also looked at all the infographics about risks of anaesthesia, etc. Then at the second consultation, I find I've got a much more informed patient who really does understand the risks and benefits of what we're proposing. Patients like it because they've got all the time that they need to get familiar with the risks and benefits of the proposed surgery. I like it because it's very difficult for me to miss an important complication. In a case in the NHS just before I started using Concentric, where a digital nerve injury wasn't documented on a consent form for a hand fracture, cost our trust, I think, £70,000, £30,000 to the patient and £40,000 to the lawyers. So I feel protected. I can't miss any risks. It also reminds me to and takes consent for photographs and blood transfusions and all the other things. And then on the day of surgery, rather than having to fill out a private hospital's consent form and repeat everything on the Concentric form, Concentric allows me to print off a PDF, which I staple to the hospital's. So it's a signed PDF that summarizes our conversations and the consent forms that may have been signed many months in advance, that's dated from many months in advance, so that I then staple to the hospital consent form and use that private hospital's consent form for confirmation of consent. And for risks and benefits, I can just write C Concentric consent form. So I've got no hesitation in recommending it. It has revolutionized my practice. My consultations are less about going through risks and more about getting to know patients and understanding what they really want. And patients are much better informed than they ever were when I was using paper-based consent. I hope you found that helpful. Good evening.
So that was Adam's take on how he's found it useful. I will try and stop sharing my screen. Right, hopefully we're back. Sarah, have we had any questions come through yet?
Yes, we've had a couple of questions come through, and Paul has kindly replied to some of them. But I'll just go through the ones that hasn't been responded to. So someone did ask, did it say it looks interesting? Are there any options for consent form, i.e., vulnerable adults without capacity?
Yes, there are. So for adults and children, but if you don't have capacity, you can do a consent form 4, and then that will take you through all that process and best interest decision making, etc. So the answer to that question is yes. It does all the different sorts of consent forms, paediatrics, adults, and consent form 4 that you would possibly want to do.
Another question around cost. So what are the costs involved if an individual wants to introduce into their private practice and for a trust to implement?
Sure. So the costs are very transparent, and if you go on the website concentric.health, you can see the costs for both individuals, for clinics, and for large trusts. And for large NHS trusts, it's on the government G Cloud 12 framework, so they can buy it as a tender process off, or they don't need to go to tender, they can buy it off the peg. For an individual, you contact us directly. There's a very transparent process starting at £15 a month, and we can get you signed up. So we'd love to hear from you.
Another question around integration. Is there any integration with EHR like Cerner Millennium?
So yes, at Imperial, it's integrated with Cerner. So here I could mention about that, but essentially the consent form drops into Cerner and is visible to the whole organisation. It comes as a clinical document with the tag of consent, so everyone can see it. Concentric's been written in a way that it can integrate with pretty much any existing electronic healthcare provider. So you name it, it can integrate with it. Just speak to us and we'd love to integrate with your system.
Another question from Ahmed. So is there one designed for endoscopy?
For?
It says,
sorry, I get it. Paul nodded, so I'm going to say yes, but
yes.
Yeah, endoscopy, but yeah, it's just a typo, but yes.
Yes, so I guess it covers pan surgery, so all of surgery, and pan medicine, so it covers endoscopy, bronchoscopy, and any interventional medical procedure, and then also oncology, so you can use it for medical oncology and for radiation for clinical oncology. We've in fact worked with CRUK and are listed as one of their digital exemplars. And we've worked with the Royal College of Radiologists and are listed as one of their digital exemplars and have helped them write their standardised consent forms. So this isn't just about surgery, and I don't know if there are any GPs listening to this, but absolutely this is not just a secondary care thing. It could also be used in primary care, particularly wherever you're needing a paper-based consent form, but particularly I'm thinking of minor ops clinics or consent for contraceptives.
Thank you. And that's the end of the poll as kindly replied to a lot of the questions, and that's the one we've got through. Okay,
perfect. Well, thank you very much, Sarah. So I make it that we're running just a few minutes over, which is pretty good. And I know people have probably got places to be this evening. So unless Hira or Paul had anything particular they wanted to finish off with.
No, I'll just say it also augments the quality information that you're giving that you wouldn't necessarily know to give. So when you're consenting and you tick a general anaesthetic or a spinal anaesthetic box, the patients actually get hyperlinks to the Royal College of Anaesthesiologists website with their PDF of what having an anaesthetic means. So it gives that embedded richness of information that, as surgeons, we just tick on the yellow form, general, regional, or local, and we expect the anaesthetist to provide that information. But I know in our organisation we recently had a complaint where the patient, I think they aspirated, and they wanted to know why aspiration hadn't been documented in the consent process. And interestingly, I don't think it's even documented on the Royal College of Anaesthetists website when I looked at the Concentric thing, where it pulls that information from. But it just, it enriches every element of practice. It's not just about your bit as a surgeon and the immediate risks of your operation. It talks about and signposts patients to a lot more information outside of that.
I agree.
Well, thank you both very much. So I guess final thing to say is, if anyone has been watching and wants to find out more, email me at edward@concentric.health or hello@concentric.health. Go and have a look on the website. If you've got any questions for the speakers, again, email me and perhaps I could forward them on. Thank you very much to all our speakers for taking out their Monday evening to come and speak to everyone about this. I hope you've enjoyed listening to this, and have a look and do get in touch. So thank you very much, and we'll end it here, Sarah. Thank you very much.